addiction, overdose, death. Those can be the unintended consequences of legitimate pain medications such as fentanyl and hydromorphone. This week, the province of Ontario announced its first comprehensive strategy to counter the growing problem of opioid abuse. And joining us now to assess that initiative, Dr. Bernard Lafall. He is head of the Translational Addiction Research Laboratory at CAMH, the Centre for Addiction and Mental Health. He's also a professor at the U of T's Institute of Medical Sciences. And Karen Howlett is here. She's a national reporter for the Globe and Mail, and we're glad both of you could spare some time for us here at TVO tonight. Let's hear from the Minister of Health, who made this announcement just the other day. Sheldon, roll it, please.
Opioids prescribed and monitored appropriately can be part of an effective treatment plan for patients in pain. However, more and more we're seeing patients becoming addicted to their pain medications. And we're also seeing a rise in prescription opioids being used for recreational purposes by people who are struggling with addiction. As a result, Ontario has seen a major increase in the number of overdoses, including fatal overdoses. In fact, opioid use has become the third leading cause of accidental death in Ontario. That's more than car accidents.
Dr. Eric Hoskins, medical doctor and Minister of Health for the province of Ontario. Karen, the highlights of the new opioid addiction strategy, what are they?
Okay, so this week's announcement, there's two previous announcements that came before it. In May, Hoskins made naloxone, which is an antidote for overdoses, available free of charge in pharmacies across the province. And that initiative followed the federal health minister saying that naloxone could be dispensed without a prescription. So that was an important measure to deal with the symptoms of this crisis. And then a couple of months later, Hoskins announced that he is going to no longer have the province's public drug plan pay for the high-dose opioids. And that's anything defined as anything equivalent to 200 milligrams of morphine a day. So those two things happened ahead of this week's announcement. This week, there were a number of measures. Probably the most significant one is making Suboxone, which again is a treatment for addiction, listing that on the province's drug plan as the primary treatment for addiction.
So if it's on the province's drug plan, that means what?
That means that anybody who's eligible to have their drugs paid for by the province gets that drug first, and it supplants methadone, which for several decades has been the #1 treatment.
Okay, so those are the three big markers in the lead up to the developments of this week. Bernard, Ontario's Chief Medical Officer of Health, has been given a new responsibility. He is now going to be the first ever provincial overdose coordinator. What does that mission entail?
So I think this is a very important signal that this is becoming a high priority item. The goal of this function primarily will be to create a system to monitor the crisis, have an idea of exactly how many people are dying from overdose on a timely basis, and also create a system to report this information to all parties involved.
And let me get your take on one of the things Karen just said, because we now understand that high-strength formulations of long-acting opioids are no longer going to be covered under the Ontario Drug Benefit Plan, starting the new year, I think, starting January 1st.
That's correct.
So effectively, what does that now mean? What's the effect of that?
So I think it means that for those that are prescribed those high-dose medication and that currently get reimbursed under the public system, there will certainly need to be decreasing the dose of opioid for them to be continuing to be covered. But the ultimate goal of the minister with this change is to allow for a reduced number of people that get exposed to high-dose opioid, because we know that those people are at more risk of overdosing.
You're a doctor, so does that mean doctors will no longer be able to prescribe these drugs if they're not covered on the drug benefit plan?
So no, doctor will still be able to prescribe those. What is changing is the way the province will reimburse for those medications. And so what the minister is trying to do is to reduce the number of prescriptions for very high-dose opioid. And this is aligned with some recommendations that has been put out in the United States by the CDC that many prescriptions are too high, produce some risk. And so there is a trend right now going on of trying to reduce those doses of opioid.
Any backlash to this?
There has been some backlash among in the palliative care community. Now, the interesting thing is that those are the very patients that opioids were originally designed for, people with terminal cancer problems and the terminally ill. So some of the palliative care doctors have very vehemently spoken out against this. I'm not sure if the province is going to try to find a workaround around that so that they can still prescribe these higher dose medications to their patients. But the interesting thing is there was a study done that shows that only a very small number of palliative care patients are actually on the high dose opioids. It's actually, I think it's 1 out of every 10.
So this ought not to have an impact on too many people.
Correct.
Having said that, you know, if I see a deadline January 1st and it's now the middle of October, meaning I've got 2.5 months before the deadline hits, common sense tells me a lot of people are going to try and load up like crazy in the interim. Isn't that fair to say?
Well, I don't know if they could do that because of the way the drugs are dispensed. So I don't think they could load up in advance and have the drugs paid for. What some people have said, if you can't give, say, a higher dose, say a fentanyl patch, then maybe you would give a patient more than 1 patch. Now, some doctors have resisted that too, saying, I'm not going to wallpaper my patient. That was one of the more colorful quotes from
wallpaper.
one of the... Yes.
Wallpaper,
yes.
That's a good one. I haven't heard that one. You wrote this back in April, Karen. Let's bring this up, Sheldon. Ontario is unprepared for an influx of illicit fentanyl and other toxic opioids, warns a letter signed by more than 200 physicians, medical officers of health, and addiction and harm reduction organizations. The letter, addressed to Premier Kathleen Wynne and Health Minister Eric Hoskins, says the toll from the opioid crisis in Ontario, quote, is poised to rise sharply given the presence of non-pharmaceutical bootleg opioids, specifically bootleg fentanyls in both powder and pill forms in several Ontario communities. Where are these illicit or bootleg opioids coming from?
Unfortunately, they're coming into Canada with grade E's from China. So the people are smuggling in the raw ingredients, or known as the precursors. They're also bringing in pill press machines so that they can stamp out illicit, bootleg versions of popular brand name opioids like OxyContin. It's perfectly legal to bring in a pill press machine. I don't know why you or I would need one, but nonetheless, you can bring those in. And the other unfortunate thing is our border agents are not allowed to open any package under 30 grams. Now you might think, oh, well, that's okay. But the thing with fentanyl is a little goes a long way. So you can have a very tiny amount. And so what they do is they break it up into very tiny packages, and it just slips through.
Because it comes under the 30 grams?
Yes, yes. And you can make just huge profits.
Bernard, has there anything that the Ontario government has done in the 3 announcements that Karen opened our program with that you think has made the province better able to deal with the bootleg opioids?
Yes, certainly. I think the major issue behind this is the problem with chronic pain and how chronic pain is managed. And
we're getting better at that?
And so certainly, like the steps that have been announced, which are creating a series of clinics that will be set up to cover pain more appropriately, is an excellent step, because that will certainly allow to better practice, but also disseminate this training to more practitioners within Ontario. So I think this is an important step.
Another part of Wednesday's announcement earlier this week was that there's going to be money put into 17, as Bernard said, chronic pain clinics across the province. Do you know where these are going to be located?
They're largely going to be in some of our biggest hospitals in some of the biggest cities. Toronto is slated to get 6 of them. There's Hamilton, Ottawa, London, but they're not going to be in some of the more remote and rural communities.
Where this is really a crisis.
Yes, that's correct.
We were in Sarnia several months ago doing a
Yes.
program focused on this very issue, and they've got a huge problem there.
Yes.
But they're not getting a clinic?
No. Thunder Bay is. That's about the only one, and of course, opioids are a huge problem in Thunder Bay.
Can the chronic pain clinics, these new ones and maybe ones that already exist, can they really put a dent in this?
So I think you have to see where the major population is located. So those clinics clearly will deserve the majority of people in Ontario. And we are certainly thinking for the future that there will be more access through things like telemedicine and network of practice. So hopefully those clinics will help. But I agree, like the example of Sarnia is excellent here. We certainly need to have a provider well-trained in those communities as well to provide easy access.
I mentioned we were in Sarnia a few months ago doing a program on this, and one of the guests on that program said that fentanyl became a much bigger problem in that community when OxyContin was delisted from the provincial drug registry, right? The idea was we'll deal with OxyContin, but of course you deal with that and it's like grabbing a balloon, right? Now the problem is somewhere else. So is delisting some of these more potent opioids now going to get to the heart of the problem, or is it going to cause the same issues that we've already seen?
So that's why the solution is not just based on how you tackle one product itself, because there are many opioid drugs that are now available in circulation. Some of those get prescribed by physicians, some of those get imported illicitly. So it needs to be a comprehensive strategy. But what you can see when you look at what happened in the last 20 years is that overall the number of opioid prescribed has been increasing, but it's not 100%, 200%. It's tenfold type of prescription increase. So that has been never seen in the history of opioid in the Canada and United States. And in parallel to this increase of prescription, you can see a parallel similar increase of the number of problems and number of deaths. So that's why the overall idea of trying to decrease overall number of opioid prescribed certainly is the only way to tackle the problem ultimately.
The minister, I guess, made his announcement in part based on the advice that he got from your committee, I mean the Methadone Advisory Committee, of which you are a part, suggested the following, and let's read this quote. Of all the provinces and territories, Ontario has the highest rates of opioid prescription, and rates of addiction and overdose deaths continue to increase. Let me get both of you on this. Karen, you first. Does the medical community understand the extent to which some doctors appear to be overprescribing opioids, and that has contributed to this problem?
And that's the very heart of the problem. That's where it started, with the overprescribing of opioids, drugs that have lots of risks, and where the benefits are somewhat questionable. And that's the missing piece here. We've been in the throes of this opioid addiction for more than a decade. And there has been nothing really substantial that says we need to rein in. We need to get doctors to prescribe these drugs differently. You'll notice from Eric Hoskin's announcement this week, he did announce measures on that front, but they're not going to be in place for another 18 months. Well, people are going to keep dying, and they're going to die in higher numbers because of this bootleg fentanyl. So that's really more needs to be done on that. The Centers for Disease Control in the U.S., they brought out new guidelines in March, which, by the way, the recommended daily dose is 1/4 of what the recommended daily dose is in Canada right now. So you would think, why don't they just do what BC did and just adopt the CDC guidelines, because they seem to make a lot of sense.
On the other hand, I think we can probably appreciate a doctor who gets approached by a patient saying, I'm in agony, you got to help me, doc, just please fill my prescription again. And I guess a lot of doctors do. Is that fair to say?
Sure, there are some pressure sometimes from patients that will require opioid script, but I think overall there is a perception that the landscape has changed completely. So what we see right now at the Center for Addiction and Mental Health, for people coming to seek help for opioid problem, are not anymore the people injecting illicit drugs. What we see mostly are people that have started their opioid trajectory on painkiller and then lost control on their use and ultimately sometimes go by on the street because they have been hooked to opioid and they need to sustain their habit here. But this is the end of the problem when you have the users that have lost control. And I think some of the measures that has been announced by the minister are immediately applicable to try to help by providing better access to Suboxone, which is a medication that help a user get off their use of opioid drugs in a way that is much safer than methadone. So I think those are steps that are immediately done. The changing of the practice is a more complex thing to organize. It requires lots of professionals to agree on their practice and what they should be. So I think this is something that is starting now in Ontario, and I hope this will get done rapidly because the problem is really pressing.
We have talked, Karen, about the role of the Ministry of Health in this, about the Government of Ontario, about medical doctors in the province, to a certain extent, patients as well. What about the drug companies? What role do they have in solving this?
That's a very good question, because that's where it started. I mean, as I said, opioids were originally developed for people with cancer. They weren't developed for people who have fibromyalgia or persistent back pain until Purdue Pharmaceutical came along and developed OxyContin and marketed as a drug that was safe and that could be used to treat moderate to severe pain. And that's where the whole thing started with the marketing by the development of the drug by the drug companies, the marketing, getting the medical community on board, and with it was the approval of Health Canada. I mean, all the way through there were no obstacles.
I don't want to impute anybody's motive here, but the fact is that the bigger the crisis, the more they sell. I mean, that's fair to say, isn't it? So where is their interest in trying to bring this to an end?
That's a good question too, yes.
We're just going to leave that in the ether for the moment, eh? Okay. Bernard, I want to ask you about, actually a guy who's been a guest on this program many times, the Nipissing MPP Vic Fideli, who had a bill passed, I guess it was December 2015, called Bill 33. And it was basically a patch-for-patch program. If you want a fentanyl patch and you're a patient, you got to bring your old patch back before you get a new one. Patch for patch. Has that been effective?
So I think the idea of the program here is to reduce diversion, so people that will sell their patch. So certainly this has been implemented in some small communities, and there seems to have been some positive impacts there. But so it seems reasonable at this point to think it's something useful to reduce the diversion of those patch, and that's why I think the minister has decided to implement this measure. It will need to be tracked down. Certainly, the limit of this measure is that it only targets one product, and we know that right now the problem is beyond the fentanyl patch. It's all the illicit drugs that are coming in as well.
Got about a minute left, so let me get a brief answer from each of you on this. There are going to be public consultations over the next few months by the Government of Ontario on this issue. Advice for the minister. What does he need to know to make this thing go away?
So I think the advice here is really to hear to every party involved. I think the issue, as mentioned earlier, of the palliative care physician is clearly an important one, because we want to have people that are in severe pain, that really have a legitimate need for opiate, to be able to access those opiates. But on the other hand, we don't want to have people overusing opiate, and we need to bring all parties together to solve this.
I know journalists aren't in the habit of giving advice to politicians. However, you've been following this, so what do you think you're going to hear?
We need some system to monitor it. We need a national database that tells us in real time how many people are dying from opioids. We don't have that. And we should also have some kind of a database that tells us how many people are going into emergency with overdoses. How many times are ambulances dispatched because somebody is having an overdose. The more we know about the toll this problem is taking, the more it's going to be on everybody's radar, and it's going to get the attention it should be getting.
What an interesting idea, that to solve a problem, you might need some facts about the problem in order to solve it. Neat. Okay, Karen Howlett, Dr. Bernard Lafall, good of both of you to join us at TVO tonight. Thanks so much.
Thank you.
Thank you.
Help TVO create a better world through the power of learning. Visit TVO.org and make a tax-deductible donation today.